Good morning, everyone. My name is Dr. Bradford Lee. It's so nice to be here with all of you. Thank you for the tremendous interest from around the world. And I apologize, I am coming to you from beautiful Hawaii, but it's probably very late at night, both in Asia as well as in Africa and Europe. But thank you for tuning in or for watching this later. Today, we're going to be talking a little bit about orbital trauma and thinking about what patients might need surgery, when is a proper time to have surgery, and then how can we really optimize their outcomes for success. A little bit about myself. I did my undergraduate studies at Harvard University, followed by medical school at Stanford. I did my ophthalmology residency at Bascom Palmer Eye Institute in Miami, Florida, followed by a oculoplastics fellowship at UC San Diego with my dear mentors, Dr. Don Kikawa and Bobby Korn. For 6 years, I served as Bascom Palmer faculty in oculoplastics. And then about 2 years ago, I moved back home to Hawaii, where I'm from, where I started my own private practice and joined the University of Hawaii faculty in ophthalmology. Certainly one of my highlights of my career thus far has been being a volunteer faculty with Orbis. In 2019, I had the wonderful opportunity to work with some amazing ophthalmologists in Jamaica and throughout the Caribbean. We evaluated lots of patients, had a lot of interesting cases in the operating room, and it was just really a spectacular week trip. So I hope all of you have had the opportunity at this point, or if not, in the future, have a chance to join one of Orbis's trips. So today, we'll start by talking a little bit about evaluating the patients with orbital trauma and fractures. We'll question the traditional thinking and teachings about fracture repair. And then finally, we'll think about who really needs to have fracture repair and when is appropriate timing. Let's first talk about the logistics of orbital trauma. When patients have orbital trauma, you may be called to see them in an ER setting, or they may just walk into your ophthalmology clinic days to even weeks or months after their trauma. When you see them in the ER setting, it can be a little bit more chaotic and not exactly what we're used to as ophthalmologists. Some of these patients may have very high energy, high impact blunt force trauma that could result in other life-threatening injuries. There may be other services involved, the ER doctors, the trauma service. In the US, most trauma centers have what's called face call. And this is typically either plastic surgery, ear, nose, and throat, or otorhinolaryngology, or oral maxillofacial surgery, because a lot of times facial trauma can involve the maxilla and the mandible. And as ophthalmologists, we have no interest and are not trained to do maxillomandibular fixation. So typically the face trauma team is the first one to see the patients. And then they might get us involved either as ophthalmologists or as oculoplastic specialists. So my first question for all of you is, in your setting, in the hospitals that you work at, which specialty is most responsible for orbital fracture repairs? As you're finalizing your choices, I will say that a lot of these other services, they're generalists and they may be not as comfortable and specialized with the expertise around the eye. So it looks like the majority is handled by oral maxillofacial surgery, but ophthalmology is called in fairly frequently to help manage these repairs. That's great. All right, so let's talk a little bit about the history when you first see a patient like this. So it's very important first to consider the mechanism of injury, because this determines the risk to the orbit, the face, and the brain. So again, if this is a softball injury or a baseball injury that hits the orbit or the eye, that's a very different scenario than if someone was struck by a motor vehicle or had a big agricultural accident or was the victim of a big assault. So you really need to think about triaging the eye, the orbit, the brain, the cervical spine, and the patient's life in some situations. We always have to ask about visual symptoms, because as ophthalmologists, we realize that there's can be intraocular injuries here, which might actually take precedence over the orbital injuries. So classic things about, visual changes, retinal detachment symptoms. We always ask about diplopia. And, this is something that you really have to push the patient for, because I've certainly had patients tell me, no, doc, I have no diplopia. And I ask them to look up and they say, oh yeah, I do have diplopia. So you really need to press them, ask them to look in different gaze positions and document if they have pre-existing double vision, because that's one of the main indications for fracture repair and something that we're going to be tracking over time. I always like to ask them, do you have a pulling sensation or like a tight pulling sensation or pain in specific gaze positions? So if they do have an entrapped inferior rectus muscle, they'll classically say, ouch, I feel that, it pulls or it feels sudden pain when I look in a specific direction. We all have heard of the oculocardiac reflex, which is something that is very concerning because it can almost stop your heart. And so I have seen patients where their heart rate has almost stopped due to traction on the rectus muscles. And this can present symptomatically as lightheadedness, nausea, vomiting. And then I also say that it's very important to ask about a past ocular history. This is something that we're very used to for patients coming into clinic, but I find that sometimes when people are called into the hospital to see a patient, they assume that they're a normal patient without any past ocular history. So you really want to know if they've had a history of strabismus or strabismus surgery or severe thyroid eye disease or pre-existing double vision. You don't want to get mixed up and think that this strabismus is all new and due to their orbital trauma. Let's talk a little bit now about the exam. So in addition to doing your regular standard complete eye exam, it's very important in evaluating orbital trauma to focus in on the motility exam. And so I like to think about the motility in vertical, horizontal, and global muscle restriction. So if you are concerned about an entrapped floor fracture and the inferior rectus muscle, you're really looking for a specific pattern of vertical restriction and pain in both up and down gaze, because that muscle is pinched, and whether you're trying to look up or down, it's going to hurt when they move their eye. If you have a very specific pattern of double vision and pain and restriction in horizontal gazes, that could suggest an entrapped medial rectus muscle or a medial wall fracture, which is much less common, but can certainly happen. And then finally, you may have a pattern of global restriction. And we've all seen patients with severe retrobulbar hematomas, and these patients have trouble moving their eye in any direction. And that has to do with the compartment syndrome. Everything is just so tight that they can't move their eye. And so if you have a generalized or global restrictive pattern, then you might chalk that up to maybe a retrobulbar hematoma, severe tissue edema, but it's less concerning for a type of entrapment. Finally, some people teach that to do force duction testing, where you grab the rectus muscles with forceps and forcefully move the eye up and down. But I really find that this is not something I almost ever do. I evaluate the patient clinically and with the CT scan, and I can pretty much tell who has muscle entrapment and who does not. One of the classic findings of an orbital fracture repair is V2 or trigeminal nerve hyposthesia. And so they have a reduced sensation, numbness in the cheek, upper teeth, sometimes even a little bit along the side of the nose. And they'll say, oh, it feels like I went to the dentist because it's all numb. And the reason for that is that the infraorbital nerve travels within the floor of the eye socket. And so certain fractures, if it disrupts that infraorbital nerve, you're going to get a numbness, which in many times will improve at least somewhat over the first 3 months or so. We've already talked about the oculocardiac reflex, but take a peek at their monitor and make sure that they don't have bradycardia or hypotension. And then it's so important to document the exam with photos and a good motility video. So I always ask my staff and my medical students and residents and fellows to take videos, have the patients look up, to the sides, down, even from what we call the worm's eye view, where you tilt their chin up and look up at the ceiling. And this helps you capture the degree of exophthalmos or enophthalmos. And then I can even sometimes engage patients to take their own photos at home as a way of monitoring their progress. And sometimes they're remotely and they share their videos and photos with me. And I can tell them based on the photos they share that their motility has improved, that they don't have severe enophthalmos, and it's a very helpful exam. Finally, if patients are very critically ill, they may be intubated and unable to talk and give you a good exam or follow commands. And so in this case, it is possible to use the doll's eye reflex to try to get the patients to see if there's muscle restriction as well. There can be other types of complicating factors in the orbital fracture patient. So intraocular injuries are extremely important, whether this is a ruptured globe and a hyphema, a retinal detachment. These are all very important things that are relative contraindications or sometimes hard contraindications to going in for orbital fracture repair. With a ruptured globe, this is something that you typically focus in on the ruptured globe because you don't want to be trying to fix a fracture and putting a lot of traction on the globe, raising the intraocular pressure and potentially expulsing the vitreous, the aqueous, the uvea. Orbital emphysema is something that we always warn patients about. So typically we talk to patients about not blowing their nose and not pinching their nose when they sneeze. Because what happens if you do that is that you can blow air from the sinuses into the orbit, and it can also cause a compartment syndrome because sometimes that air gets trapped and cannot get out of the orbit. So I always tell patients, if you need to clear your nose, you can suck air in as much as you want. You can sniff in like that, but please do not pinch and blow. And then finally, sometimes orbital fracture patients come into us having had multiple prior surgeries. And this is extremely challenging because oftentimes the prior surgeons have already caused scar tissue, they've disrupted the blood supply, and it makes everything more challenging and more prone to scarring and poor outcomes. This poor patient over here came to me with about 12 to 15 prior surgeries. And she had, as you can see along the floor, she not only has a fracture, but she had a calvarial bone graft where they took a bone tissue from her skull, used it as an orbital floor implant. And you can see it was not a very anatomical repair. It does not look like a mirror image to the other side. That then caused hyperglobus, and the surgeon said, well, let's take another bone graft and put it on her roof to push the eye back down. So she had that done. She had severe scarring of the muscles, severe restrictive strabismus, lid malpositions, and it just made the final repair very challenging and not as good an outcome as had she come to us primarily. So our next audience response question is, which situations would make orbital fractures contraindicated? Okay, so most of you wrote orbital emphysema, which actually the correct answer is hyphema. If you have a hyphema, there is concern that manipulating the eye and the orbital tissues will disturb that hyphema. The red blood cells can clog the trabecular meshwork, and you can cause, a severe rise in the intraocular pressure. So orbital emphysema is something that can be addressed. Sometimes you have to place a needle in to allow that air to egress out of the orbit. But sometimes if there's a large fracture, the air can come out on its own. So that is something that could be associated with an orbital fracture repair. But if needed, you actually have to address that. And so it's not a contraindication for orbital fracture repair. So we all get scared about the term entrapment. And oftentimes when you read the radiology report, they throw around the term entrapment, but they throw it around very loosely. So I'd like to clarify that there are different types of entrapment. There can be entrapment of the muscle sheaths or the intramuscular septa, and there can be entrapment of fat. What we really care about is tight impingement of the muscle. And if the rectus muscle is trapped between a minimally displaced bone fragment, it becomes ischemic and necrotic, and it will die. And what happens after that is that it becomes fibrotic, and it will never function normally again. They'll have a restrictive strabismus type pattern. And so if you have a tightly entrapped rectus muscle, that is a urgent indication for repair, because otherwise they will never have good motility after that. In addition, they could have an oculocardiac reflex. So again, in evaluating clinical entrapment, we talked about this. It's a very specific pattern of pulling or pain in vertical or horizontal gazes. You look for the oculocardiac reflex. You look on the scan and you look for that muscle. Here on this scan, you see the nice pancake-looking inferior rectus muscle on the normal side resting on the floor. And here you say, oh my gosh, where did the inferior rectus go? And you can actually visualize it poking through into the maxillary sinus through the fracture. So if you ever see an quote unquote absent inferior rectus, that suggests that there are cuts on the CT scan. So the muscle may be dipping through on one of those in between cuts, but normally you can see it poking through the fracture. I also think it's very important to look at the inferior rectus muscle conformation. So I like to call this ovalization of the inferior rectus muscle. Here you see that instead of the pancake on the normal side, it's turned into a vertically oriented oval. And what this tells me is that this patient is not only more likely to have double vision acutely, but they're also more likely to have persistent double vision because it's changed the configuration of the muscle based on how the orbital tissue has prolapsed into the maxillary sinus. Again, force duction testing may be possible, but normally is not necessary. Again, this is just another patient of mine who presented with what looked like an entrapped inferior rectus muscle. So if you look carefully, you see the fracture. Again, it's a minimally displaced green stick fracture in a young patient. And you see two different types of tissue entrapped here. You see a little bit of tissue that looks exactly like extraocular muscle tissue, and that looks very suspicious for muscle entrapment. And then you also see this dollop of fat coming down, and you see that, again, this is iso-intense with the orbital fat. So you have to think carefully and compare it and look at the radio intensity of the entrapped tissue, always looking to see if it looks like anything muscle-like coming through the fracture site. And here, the clinical correlation is that when the patient looked up, he was very restricted. He had pain in up gaze, and you notice that the left eye cannot go up as well as the right eye. So our next audience response question is, which is not associated with entrapment of the inferior rectus muscle? Okay, so let's go through the answers here. So the first one, pulling and pain and pulling is very much associated with entrapment of the inferior rectus muscle. Enophthalmos with hypoglobus is not associated with entrapment. Normally, when you have enophthalmos and hypoglobus, you have a large, more significantly displaced fracture. And so it's harder to get that tight pinching of the inferior rectus muscle. So that's actually the correct answer. The other things like slowing of the heart rate, bradycardia, can be associated with entrapment. A minimally displaced fracture in a young patient, again, that's also more classically associated with entrapped rectus muscle. And then finally, that vertical double vision without horizontal double vision with that associated pinching and pulling, that also is fairly classic for an entrapped inferior rectus muscle. So the correct answer here is enophthalmos with hypoglobus, which would be a large, more significantly displaced fracture. Let's move on to evaluating the CT scans, because this is really, really critical to properly evaluate the patient just as much as the clinical exam. So if you're going to the ER doctor has oftentimes conveniently ordered all of these scans for you, and they've decided which are the appropriate scans. But if you are the first person to see this patient, you need to decide what type of CT scan. So I normally order, if I'm just concerned about the orbit, you can order a CT orbits, and typically we do non-contrast because we're not looking for inflammation. We're really focusing in on the bone. So I'll order CT orbits, non-contrast with fine 2 to 3 millimeter cuts. If I'm concerned about a panfacial trauma, Lefort fractures, a ZMC fracture, or what we call a tripod fracture, which involves a maxilla, infraorbital rim, floor, sometimes a zygomatic arch, then you need to order a CT face. And then if you're worried about traumatic brain injury and other things, you might even have to order a traumatic a CT brain and other things. But certainly you should know about the difference between orbits versus face. When we're looking at the bone and trying to see, how large a fracture is and how displaced it is, I'd say bone window is for bone, which is very intuitive here. So this is an example of the bone window, and you can see that there's very crisp, fine definition of the bone. And here you see that depressed fracture of the orbital floor here. When we're looking at the soft tissue and trying to highlight the difference between the extraocular muscles and the orbital fat or blood, we switch to soft tissue window, which gives very nice resolution between the muscles and the fat. You see that the bones are a little bit more glary, a little bit thicker, but it shows us the nice change in the conformation of the inferior rectus muscle over here, if we're looking for ovalization or tenting of the muscle. And then finally, I like to think about orbital volume expansion and tissue herniation. So I think in my mind about the normal side and having a perfect reflection across the midline and where the anatomical orbital floor should lie. And then I think about how much tissue of the orbit has dropped down outside of those normal anatomical confines. And here you see the inferior rectus muscle change in conformation and the tissue prolapse. Now, there's also different views on a CT scan. There's coronals, axials, and sagittal views. The coronal views, which we were looking at before, are absolutely the best overall for looking at the floor, the medial wall, the tissue prolapse through the floor. The axials are really a little bit less important. Axials are not good for looking at orbital floors. They do show you the medial walls and the lateral walls in a different nice perspective. And then the sagittals, if you are the surgeon, is very good for looking for what we call the posterior ledge, because when we place an orbital floor implant, we have to balance it on a platform or somehow stabilize it so it doesn't drop right into the maxillary sinus below. So you can draw an imaginary line and think about how much of a ledge do you have to balance your implant. If you don't have a posterior ledge, that makes the repair a little bit more challenging. And then we use different techniques to cantilever the implant along the medial wall or fixate it along the orbital rim. And you can also draw that imaginary line of the normal anatomical floor and think about how much tissue prolapse it is. And that's going to determine how much enothalmos and hypoglobus they might have later. Now we're going to move in to questioning those traditional management teachings, and I'll say misconceptions. So a lot of the other services are under the impression that most fractures need to be repaired. And I've seen this so commonly in trauma centers across the country in the US. They're seen by oral maxillofacial surgery, and almost everybody gets a fracture repair within the first few days. Sometimes this is a function of the trainees just wanting to get more surgical experience fixing fractures, but we always have to think about what would be best for this patient and think about whether it really necessitates repair. And I will say that most fractures oftentimes do not need repair. And then there's also this misconception that repairs must be done within the first 2 weeks or so to have a good outcome, and that it gets very challenging to fix these fractures as it gets further out. It is true that if you do the fracture repair early on, there's less scarring and the fat is not stuck down, and it is easier to place an implant. But I will say that with a well-trained surgeon, it is certainly possible to have an excellent outcome if you fix a fracture months to years after the trauma. So we have to think in our minds and realize that you can definitely have a good outcome if you have a late or delayed fracture repair. Finally, we all know about the indications from a muscle entrapment, double vision, enophthalmos, hypoglobus, superior sulcus, hollowing aspect for disfigurement. But one of the classic teachings is that fractures involving half of the orbital floor require repair. And this is not always true, and I'll tell you why. I like to think about this instead in terms of how much orbital volume expansion has there been. So if you consider the size, if you're thinking from a volume standpoint, volume is made up of the size of the fracture as well as the amount of displacement of the fracture. So if you do a thought experiment here, you could have a very large orbital fracture, but if it's minimally displaced, that results in a minimal volume expansion. As we have greater displacement of that fragment, the volume and the amount of tissue prolapse dramatically increases. So 50% of the orbital floor is typically referring to a linear measurement on the coronal view and the size of the bone fragment. But we have to think a large minimally displaced fracture translates into very minimal volume expansion, but a large and highly displaced fracture translates into a much larger volume expansion, larger tissue herniation. I'll also say that if we're thinking about the overall orbital volume expansion, if you start expanding multiple walls like the floor and medial wall together, that dramatically increases the overall orbital volume expansion. And these patients are more likely to have enophthalmos and hypoglobus. Our next audience response question is, diplopia from orbital fractures usually resolves over which time frame? So if you were going to ask give your patient enough time as necessary to really know if the double vision is going to resolve on its own, how long should you give the patient? Wonderful. So we have the right answer here is the first 3 to 6 months. As we will talk about, diplopia very oftentimes improves on its own in almost all cases if you give it enough time. So 6 months, 3 to 6 months is what I use in my practice. 2 years it's not going to change after 6 months. So my colleagues formerly at UCSF and Mayo Clinic published a very nice review, editorial in 2018 in Ophthalmology, really making a case for why we should consider delayed fracture repair. And they came up with a few different arguments having reviewed the literature. As we've talked about, urgent repair is only indicated for true trapdoor fractures with tight impingement of the inferior rectus muscle or medial rectus muscle, where we're worried about muscle necrosis. Almost 100% of double vision resolves over 6 months. So you really need to be patient and advise a patient, don't worry about double vision. If there's no tight impingement and entrapment of the muscle, almost all of these patients will improve in the double vision if given enough time. Late enophthalmos is relatively rare, even in the case of large floor fractures. So a caveat to our prior discussion about looking at the CT scan is that a lot of times there's a hemorrhage, the tissues are all swollen, and as that swelling and the hematoma resolve, there's less outward pressure pushing the bone fragment outward. And so as that resolves, sometimes the tissues go back into the orbit, the bone fragment becomes less displaced, and the bone remodels. And if you were to take a repeat CT scan, you might actually discover that that fracture doesn't look as bad as it looked initially. So beyond that, even in patients who do have enophthalmos or hypoglobus, it's nice to let the patient make their own decision about how badly affecting their appearance and how much it bothers them. Because for the right patient, they may say, okay, well, I noticed my eyes a little bit deeper set there, but I wouldn't want to have surgery for that. And I don't want to have surgery. And they're quite happy with that. So I like to give the patients enough time for all of that edema, the hematoma to resolve, which is again, typically by 3 months. And if they look in the mirror and they say, I see some difference, but it doesn't bother me, then that indication for disfigurement has disappeared and you've let the patient make their own decision. Plate fracture repair can still fix diplopia and enophthalmos. This is very important to recognize. It may be a little bit more scarred down, require a little bit more skill as a surgeon, but you can definitely have great outcomes if you fix it months to years later. The exception to this would be if you have a tripod fracture or what we call a ZMC fracture, which involves the orbital rim, the floor, the frontozygomatic suture, sometimes the zygomatic arch, and then the maxilla. These fractures, if you wait a long time, everything scars into place, and it's very difficult to mobilize that large fragment and fix it in the anatomical position. You have to actually go in with a saw and re-osteotomize and cut all of those sites to mobilize the fracture and then plate all of them. So it's actually easier to fix these fractures, oftentimes in combination with ENT or OMFS. And that would be the one exception where we would try to go in a little bit earlier to mobilize that fragment and avoid having to make cuts with a saw to re-osteotomize them. Now, I understand that not all of you are going to be doing orbital fracture repairs and are sometimes just more involved in the management of orbital trauma. But for those of you who are doing the surgery, there are certain considerations here. I would say that, you should not attempt this procedure if you've never done it before and you've only watched YouTube videos, because orbital fracture repair and doing it well is a slightly challenging procedure, even for trained orbital surgeons. So you definitely want to have someone who has experience and good training, because there can be complications and you can cause more harm to the patient if you're not doing things properly. In terms of incision planning, I think the proper way to do this, and the one that has much better outcomes, is through a transconjunctival incision. And this is a perfect incision if you're fixing an orbital floor fracture. If you have a medial wall fracture, a transcaruncular incision is very nice. And if you have a floor and medial wall fracture, you can do a combined transconjunctival transcaruncular incision. And this way, all of the incisions and scars are hidden on the inside. There's no visible skin or subciliary incisions or scars, and the patients are less likely to develop eyelid retraction, ectropion, or unsightly scars. Navigating the inferior oblique can sometimes be a challenge. And there's two different methods. Some people disinsert the inferior oblique on the periosteum, and other people, like myself, like to hook the inferior oblique like a strabismus surgeon, tag it with sutures, and then divide it and reattach it at the end of surgery. So here you see from the Korn and Kikawa video atlas, this is a figure from there where we've hooked the muscle, we tag it with sutures, divide it, do your entire fracture repair, and then at the end, replace it and reattach it to the stump. And what this allows you to do is have a beautiful panoramic view showing the entire floor and medial wall. And it's just a little bit more precise than disinserting it and just allowing it to fall back into position, because I think in a small percentage of the time, it doesn't fall back and you risk having a little bit of torsional diplopia. Finally, one of the big challenges in fixing the fractures is that all the orbital fat just tends to billow over your retractors and spill around the implant. And this can be very challenging when you're trying to hold everything up into the orbit and very carefully place your implant on that posterior ledge. So some techniques that I like to use are hand over hand malleables. There are what's called these pie-shaped retractors that different companies make that are triangular shaped and are the size of the orbital floor. And then finally, one of my favorite techniques is to have a template, or oftentimes just a piece of plastic that you're using as a template, and that holds all the fat in, and you can just retract that template. And it's very effective for holding and retracting the orbital fat. Let's talk a little bit about implants, because I always recommend placing an implant. A super mid nylon foil implant. This is a fancy way for fancy term for a thin, flexible piece of plastic. And so this is one of my favorite types of implants. It's very easy to insert into the orbit. It's low cost. It's very flexible, and there's no metal hardware, which the patient might not like feeling after the surgery. Another of my favorite implants is what's called porous polyethylene coated titanium mesh. So there's this titanium mesh which allows it to be nice and malleable and flexible, contourable. There's these little strips where you can fixate screws along the orbital rim if necessary, but that mesh, titanium mesh, is coated so that you don't get a lot of scarring to the bare metal. These can be a little bit on the expensive side if cost is a significant consideration. Oftentimes, the companies that make these implants may have a program where they can donate these types of implants. Some people like to use these dissolvable implants or polylactic acid implants, and this can be very nice in pediatric orbital fractures because you don't have to worry about their orbital bones growing and potentially having issues with the implants down the road. Finally, I'd say, decades ago, we had to use autogenous grafts, and we saw an example of a calvarial bone graft, which is typically harvested from the skull, or auricular cartilage, which can be harvested from the ear. I understand that in certain settings, it might be easier to harvest tissue rather than have a implant that needs to be purchased. But I will say that these do have donor site morbidity. And as we saw with the calvarial bone, we can't really mold it to be an anatomical, perfect contour for the floor and medial wall. I would highly advise against using bare titanium mesh. This causes a lot of scarring and problems. Now, our implant, in addition to the material, we have to think about fashioning it into the proper size and with the anatomical contour. So like I mentioned, we have to, with this type of implant, we would have to cut it into the right size to fit the orbital floor and mold it into a triangular, or what we sometimes call a guitar pick shape. The implant should be larger than the defect because you don't want the implant to be too small so that it's shifting either horizontally or vertical or anterior posteriorly, because then it can expose the fracture and have re-entrapment of tissue. A nice technique is sometimes to contour it in a way that it has a wing for the medial wall as well as doing the floor, and it's very easy to slip these types of implants in along the floor and medial wall. One tip is that I always like to place an implant to avoid re-entrapment. I have seen cases where an implant wasn't placed and then the tissue re-entrapped. So I always like to put something to prevent re-entrapment. And then these are some of the newest types of implants that have come out in the US. And these are pre-contoured implants that are fashioned to the anatomically averaged adult orbit. And so these are really nice. You don't have to worry about cutting out an implant yourself and molding it. And sometimes you need to trim off the wings just a little bit to fit it in properly, but these can be a nice option. And my colleagues and I at Bascom Palmer, we published our experience and had very nice outcomes using these pre-fabricated and pre-contoured implants. Finally, let's talk a little bit about implant fixation. Ideally, we do it in a way that avoids palpable titanium screws and hardware, because the eyelid skin is very thin, and if you screw in a titanium screw and fold these little titanium rings over the orbital rim, it's sometimes visible and it's sometimes palpable to the patient. So normally when we do fixation, we're trying to avoid anterior migration of the implant because you don't want it to jut forward and have the patient feel a rim of the implant over here. So the most elegant technique, which I typically do in my practice, is just by carefully closing the periosteum, typically with a 5/0 vicryl suture. And this avoids all the hardware. So what I do is I cut off the metal rings over here, and I just carefully close the periosteum, and that prevents anterior migration. You can also use a screw that's placed behind the orbital rim through the thick zygoma over here. And if it's a little bit hard to get the proper angle, you can see this is thick bone that you could screw into here. And if it's done at the right angle, again, we avoid any type of palpable hardware around the rim. Finally, if there's really no posterior ledge and you have no other option, you can use these little ring tabs and put in a titanium screw. But it is palpable, and it is always that kind of permanent reminder that the patient has hardware and that they had a trauma. We talked a little bit about the posterior ledge, but when you're doing the fracture repair, it's absolutely critical to find that posterior ledge to seat the implant properly so that the implant doesn't fall into the orbit. My colleagues and I at UC San Diego published a paper and a large series of secondary orbital reconstruction in patients who had prior orbital fracture repair that was not done properly. And so here you can see a patient presenting with hypoglobus, enophthalmos, and a superior sulcus deformity. And on her imaging, you see that the floor implant is too far down. And on the sagittals, you see that it's not resting on the posterior ledge. It's falling way down into the maxillary sinus. So they didn't dissect back enough, find that bone, and place the implant on that bone. This is after repair, and you can see that even though it's a delayed revisional procedure, she has nice improvement in the hypoglobus, enophthalmos, and superior sulcus deformity. And this was a very interesting patient. On the sagittals, you see that she did not have much of a posterior ledge, and clinically, you see that she has restriction and upgaze. You see that on the coronals, you see that the implant is too high up. It's not at the anatomical floor. And what was happening was that they canted the implant way upwards so that when she looked upward, it actually impinged on the optic nerve, and she was having transient gaze-evoked visual obscuration. And so this was very disturbing. We had to remove this implant, properly place it, and we fixed it, and she has improvement in the hypoglobus, enophthalmos. Unfortunately, she did have some scarring, from the prior surgery. So you can see there is some lid retraction and upgaze, but at least her vision was better. Her enophthalmos and the hypoglobus was better. So our final audience response question is, what is not a potential complication of orbital fracture repair? In other words, all of the following are potential complications of fracture repair, except. Perfect. This was easy. So you all got that. But this is just to highlight the fact that there are things that can go wrong with orbital fracture repair. It's not a beginner orbital surgery. And if you don't have the expertise and you don't have colleagues who might have the expertise, you can call Orbis and have them send in some docs to help you. But definitely don't try to do anything that's dangerous or would cause more harm to the patient. Finally, this is an interesting technological innovation that my oral maxillofacial surgery colleagues in Miami had started doing. They had a series of malpositioned implants, who they had to keep taking back to the OR. And they said, hey, we got smarter. We now use intraoperative CT scans. So you can roll this portable CT scanner into the OR, get a scan of the implant after it's placed, and double check yourself right then and there to make sure that the implant is in proper position. So this is from an article that showed first try, not on the posterior ledge. Second try, also not on the posterior ledge. Third try, we've confirmed that it's on the posterior ledge. So if you're really not sure about the implant position and you're not as familiar with the orbit, you could potentially check your implant intraoperatively and then make sure you got it right before closing up. So in conclusion, a detailed clinical history and exam and a review of the CT scans is very, very important in determining who needs urgent repair or who could have a late and delayed fracture repair. If there's no true muscle entrapment, I like to wait at least 3 to 6 months to allow patients to have the double vision resolve and see their final aesthetic outcome and let them make the decision if they would like to have it repaired. Orbital volume expansion is how we should be thinking about who might have late enophthalmos and hypoglobus, thinking about not only the size of the fracture, but the displacement and the amount of tissue herniation. And then finally, please emphasize to your patients that late repair can be very successful to correcting enophthalmos and diplopia. And even if they don't have access to a surgeon in the next months to year or so, they can always wait for the right person to come and have their fracture fixed, whether that be through Orbis or through visiting oculoplastic surgeons or through just going somewhere else to a higher acuity hospital. So thank you very much. It's been a pleasure to spend the morning with you over here. please feel free to reach out to me over email or check me out on Instagram. And what I will say is that if you do feel that you need more training and would like to raise your level of care in orbital trauma and fracture repair, please let Orbis know. There was an overwhelming response to today's lecture. We had almost 1,400 people register for this event, and we'd all be very happy to make a trip out to visit with you, work with you. And the ASOPers, the American Society of Ophthalmic Plastic and Reconstructive Surgery, has a foundation, and there's a big interest in global ophthalmology. So if you are interested in partnering with ASOPers, there's a lot of us who are very interested in helping overseas. So please reach out to ASOPers as well. Thank you very much. And we'll move into the question and answer section. Okay, so our first question is, what is the optimal timing for a fracture repair? So I think we pretty much covered this. We talked about entrapped muscles need to go right away as soon as possible, ideally within 24 hours, but without the concern of muscle necrosis and ischemia, we like to oftentimes wait that, about 3 to 6 months, see if they really need and meet those indications for repair, and they can always have a delayed fracture repair. Okay, our next question is, does enothalmos progress over time? It does. So like we talked about, as the tissue edema resolves, as the orbital hematomas resolve, things will go inwards. So I always tell patients that enophthalmos will you'll see your final enophthalmos and hypoglobus results around 3 months after the trauma. And at that time, if you're not bothered by the enophthalmos or hypoglobus, it shouldn't really get worse at that point. Our next question is, if I have a trapdoor fracture with a hyphema, should I wait or should I repair it? So definitely, like we talked about, the hyphema takes priority because we would hate to throw someone into severe, not angle closure glaucoma, but having the RBCs clog the trabecular meshwork and have uncontrolled ocular hypertension and glaucoma from that. So the hyphema takes precedence. You'd keep them on bed rest until the hyphema resolves. And then later down the road, as we've talked about, you can have great outcomes with late or delayed fracture repair. So there's the intraocular injuries take precedence. Our next question is if enophthalmos is more than 2 millimeters and diplopia is gazing and primary gaze and deviation of more than 30 degrees, even then, should we delay surgery? So we talked about how the diplopia can resolve, and in most cases, it does resolve over the first 6 months. So again, seeing diplopia early on that's not an indication for repair. Enophthalmos, if you have severe enophthalmos and hypoglobus early on, as we talked about, if anything, that's probably going to get worse over time. So if that's the case, and it's just going to get worse, and they already think that it's unacceptable for them, that could be an indication to maybe do the surgery a little bit sooner. Do you use 3D implants? Any experience about those results? So I have used custom implants before. They are very, very, very expensive. So these would be for very special circumstances. With 3D implants, I think what this question is about is it mapped and custom fit and 3D printed to the anatomical other side of the face that's uninjured. And in the US, these implants can cost up to like $20,000, $30,000 for the whole process and 3D imaging and printing. There's also sometimes 3D implants referred to the 3D pre-contoured implants, which I showed you previously. And these are also expensive, but I think in the US, they're more on the $2,500 range, not $25,000 range. And so I have used those pre-contoured 3D implants, but those are not the 3D printed, mapped through CT scans to the patient's individualized contralateral side. Another question, up till how much time can we repair floor fractures, after which time it will be of no value? I would say there's no limit. So we once had a patient who had a fracture like 20 to 30 years ago, just had not been in the right place and the right time to have it fixed. we were able to fix it for him beautifully, and he had a great outcome. So there's really no expiration date as long as you're comfortable and trained to do those fractures. Could you please bring the image with your email? Thank you. Yes, the image, I can just tell you one more time, my email address is Dr. Lee, DRLEE, at Oculoplastics Hawaii. That's OCULO, Oculoplastics, PLASTICS, Hawaii, HAWAII.com. So Dr. Lee at oculoplasticshawaii.com. Can orbital fracture repair cause any damage to the infraorbital nerve? Certainly, if you don't know what you're doing, you can damage the infraorbital nerve. But more commonly, when we do an orbital fracture repair, we talk to patients and say that you may have some numbness again after the fracture repair because we have to pull and stretch on that nerve a little bit. Obviously, it would be very problematic if you cut through that nerve, and that should never happen. But if you're just dissecting the orbital tissues off the infraorbital nerve, sometimes you can get a little temporary neuropraxia. They have some transient numbness, which again, it typically gets better over the first 3 months. Management of post-traumatic lacrimal canal obstruction, when and how? So this is kind of not the focus of our lecture here, but I think the question is about canalicular lacerations and scarring, and how do you fix this? Of course, we try to do this early to intubate the lacrimal canaliculus to avoid this, but if it happens later, sometimes if the obstruction and the scarring is very proximal, you can cut down on the canaliculus, find the patent distal canaliculus, and place a stent and create a new punctum for the patient. So that can be a nice option if the cut is fairly proximal. If it's more distal, sometimes you can try using a lacrimal trephine to core through the scar tissue. But if there's a big displacement of the canaliculus, you can't just core through and get into the new segment. It has to be relatively lined up. And if there's scar tissue, you can use a lacrimal trephine to core through that. If you have a traumatic globe avulsion and medial wall fracture, how would you approach that? So I think when you say a globe avulsion, that could mean, you have trauma or disinsertion of the medial rectus muscle. Sometimes you can have trauma to the optic nerve or partial trauma to the optic nerve. In those types of situations, those are always challenging. Assuming that the globe is okay, if you think that you could reinsert the medial rectus muscle, you could try to do that. But it's very important when you're thinking about disinsertion and trauma cut through the medial rectus muscle, you have to understand that the innervation of cranial nerve 3 branch to the medial rectus muscle innervates the muscle in the posterior 1/3, 2/3 junction. And if you have disruption of that innervation, that muscle is never going to work and it's never going to move properly. And this is a problem in cases where ENT has done, for example, an endoscopic sinus surgery. They've accidentally fractured through the lamina papricia and eaten a portion of the medial rectus muscle. And those are very challenging cases because if they've disrupted and de-innervated that muscle, the muscle will never function properly, even if you go in and repair the muscle. So in those types of situations, I think you'd have to think about that. But I would more likely than not just delay the fracture repair, see how things go, see what the double vision is like. And their first priority might be to try to get a better eye alignment first. Next question, can hyposthesia remain after fracture repair? It can. Normally what I tell patients is that if you have numbness from damage to the infraorbital nerve that does not get better after the first 3 to 6 months or so, it's probably not going to get better at that point. Normally with orbital fracture repair, if it's done properly and you're just lifting or releasing the scar tissue off of the infraorbital nerve, you shouldn't cause permanent nerve damage. The infraorbital nerve is a very, very thick nerve bundle. So you'd have to really cut into the nerve. But if you're just peeling off the tissue, even if you got one or two axons, while you're dissecting it off, it's a very, very thick nerve bundle, and you really shouldn't cause permanent worsening hyposthesia. Have you ever used xenograft bone grafts before? If so, how was the outcome? I honestly have not used xenograft bone grafts. This would be like a cadaveric bone graft from another dead patient. I haven't even used cadaveric bone grafts from the same patient because, one, the morbidity, and two, we talked about the malleability problem. It's just not as good as what we have for alloplastic implants. All you need is a very thin piece of plastic, which ideally is indicated for implantation in the human body. I have heard of cases in resource poor settings where they've improvised implants. I heard in certain countries, they take, sterile saline bottles and just cut out a thin piece of plastic and use that as the implant. I can't say I endorse that officially because, anything that you put in a patient's body, it should be cleared for true implantation in the human body. But yeah, just having a thin plastic implant like the super mid nylon foils, those are very inexpensive, and I think hopefully are not cost prohibitive, even in a resource poor setting. Do you consider fillers for traumatic enothalmos? That's a great question. So, if the only concern is enophthalmos and superior sulcus hollowing, you can actually use either soft tissue fillers or autologous fat transfer to address the superior sulcus hollowing or to address the hypoglobus or the enophthalmos. So here the idea is that we're not recreating the anatomical orbital sides, but we're augmenting the soft tissue and the orbital fat in the orbit to prop the orbit up, to address the enophthalmos and to address the superior sulcus hollowing. I have done that, and I do fat transfer myself. You have to be careful. I like to inject along the floor of the orbit with blunt cannulas. So you have to know what you're doing. You have to do liposuction, purify the fat, and then inject with blunt cannulas along the orbital floor. And that can give a very, very nice outcome. I have a whole talk that I give about use of fat transfer for addressing reconstructive indications, whether it be ZMC fractures, orbital fractures, radiation tissue, soft tissue atrophy, but that can be a very powerful option. If you do hyaluronic acid fillers, you do have to be careful about migration of the fillers. Sometimes you think that you're injecting it into the orbit, but it's tracking back along your cannula or needle track, and then it can cause significant tissue edema and swelling in the eyelid and may need to be dissolved. So you just have to be careful with soft tissue fillers, but it can augment the orbital volume. How to manage CSF rhinorrhea. So CSF rhinorrhea is where you have a fracture along the skull base. So sometimes you have a medial wall fracture, but you also have the fracture propagating through the cribriform. And these are very difficult. I personally don't manage these myself. I would do that in conjunction with ENT, but typically they would do some type of soft tissue graft, whether it be what we call an Enduragen graft, which is a bovine collagen graft, or they can sometimes use the patient's autogenous tissue or some fat or dura or some fascia to kind of plug the hole and get the CSF leak to stop. But you have to, with a CSF rhinorrhea, you have to think that there can be nasal flora that can get inside and cause meningitis. So that is a concern with CSF rhinorrhea. And this is classically presents as a constant dripping, salty taste of constant dripping fluid in the nose and throat. How do you manage post-traumatic intraorbital hematomas if there is optic nerve dysfunction? Great question. So basically, this is a question of what do you do with a retrobulbar hematoma with optic nerve dysfunction? Well, this is classically, we have to try to alleviate the compartment syndrome as soon as possible. What happens is that there's too much compression of the optic nerve due to the hematoma, and it restricts the perfusion and the blood supply to the optic nerve. These are classically emergencies. This is where you could do your canthotomy and cantholysis. If you're having trouble doing a canthotomy and cantholysis, you can also do what's called the full thickness lid splitting approach, where if you're not trained or comfortable doing the canthotomy and inferior and or superior cantholysis, you just take a scissors and go make a big vertical cut right through the midsection of the eyelid, which is sometimes easier to do. Maybe an ER physician, is more comfortable doing this properly as well. And that widely splays open the lower eyelid and allows the globe to come forward. And that can alleviate that compartment syndrome, lower the intraocular pressure, and allow the optic nerve to perfuse. But you have to do this urgently, ideally within the first 24 hours, but really ASAP. I'm sorry, ideally within the first 1 to 2 hours, because if you have loss of perfusion to the optic nerve, you can have permanent loss very quickly. Think of it like a stroke to the brain. It's a stroke to the optic nerve, and strokes have to be addressed urgently, if you want it to reperfuse properly. Can we do squint correction along with orbital fracture repair? This is a great question. So if they needed to have muscle alignment surgery along with the fracture repair, I would say that it's better to stage this because if they have double vision, that's partially due to the orbital fracture repair. It's better to recreate the anatomical confines of the orbit, and that might already address their double vision and their motility dysfunction. So you may not have to mess at all with the extraocular muscles themselves. If they do have residual double vision after the fracture repair, after all the tissue edema has gone down, especially in primary or reading position, then that might be an indication to move forward with a strabismus surgery repair or prism glasses. But again, just like with the initial trauma, I say you got to wait at least 3 months after your fracture repair, because it's very common to have double vision after the fracture repair in the early post-op period due to tissue edema. And you have to wait for that to go down before you can appreciate the final result. How do you manage traumatic optic neuropathy? Honestly, I like to get my neuro-ophthalmology colleagues involved, but unfortunately, there's not a lot of good evidence, around this. If the traumatic optic neuropathy is due to a retrobulbar hematoma, we address that right away. But if there's traumatic optic neuropathy through shock wave or blunt force trauma, oftentimes there's really no good treatment. As you know, there's some people who try steroids, which can be plus minus. I don't think there's great evidence base for that. And steroids can certainly sometimes cause other side effects as well. Can you elaborate on OCR? I'm not sure what ocular cardiac reflex. Okay, so ocular cardiac reflex is where when you put traction or impinge the rectus muscles, whether through the muscle being pinched between a bone fragment and they're looking up, that's putting traction on the muscles, that can cause the ocular cardiac reflex, which is a severe bradycardia reaction. So you'll see the heart rate go down, they can become lightheaded because they don't get perfusion to the brain. They could get nausea, vomiting, just feel awful, as their heart is slowing down or almost stopping. And so in that setting with an entrapped muscle, I'd tell the patient to just keep your eyes closed, don't move the eye, in those gaze positions where it's causing impingement of the muscle, and then, ideally take them to the OR as soon as possible to free up the muscle, place an implant, and prevent re-entrapment of the muscle. What material do you prefer, porous polyethylene or titanium mesh for orbital floor? So as I mentioned, my favorites are either this nylon foil, which is basically a thin malleable piece of plastic, or the porous polyethylene coated titanium mesh. So these are a little bit more expensive, but you have the benefit of the malleability of the titanium mesh, as well as the benefit of the porous polyethylene, which prevents scarring of the orbital fat and inferior rectus muscle to the metal. That's the downside of a bare titanium mesh. Without the porous polyethylene coating, you get a lot of scarring and fibrosis, and it makes it very difficult to fix things later, as I've been told, if it needs to have a revision. How do you manage orbital compartment syndrome? So we talked about this, really doing the canthotomy and cantholysis, or the full thickness lid split approach, to allow the orbital contents to prolapse forward, to proptose the eye, and relieve that compression on the optic nerve. Is ocular cardiac reflex a sensitive indicator of a white-eyed blowout fracture in children? I would say yes. If you have ocular cardiac reflex, it means that, especially if it's gaze evoked, that means you're having, you're pulling on the muscle. And, but of course, we don't look at that in isolation. I'd say if you have an ocular cardiac reflex, be highly, highly suspicious. It's more likely than not that they have one, but definitely look at the CT scan, look for the muscle dipping through the fracture site, ask them clinically, hey, little boy, are you having pain and pulling sensation when you look up and down? And if the answer is yes, ouch, yeah, it hurts. And when you're looking down, yes, ouch, it hurts. That's clinically an entrapped muscle. Use of 3D CAM in orbital fractures is a very good tool in my surgeries. The time in the OR is less and is wonderful. I think in 3D CAM, I'm not sure what that means, but I think he means maybe the 3D contoured implants. But yes, wonderful. I'm glad it's working out for you. How would one help if someone is in a setting where there are no orbital implants and exenteration is the only approach, especially in children? So I think we have to clarify here. When we talk about exenteration, we're typically talking about removing all of the orbital contents for different types of malignancies. So that's removing the globe, the orbital fat, the rectus muscles, everything in the orbit. So we typically think of that more in the setting of maybe rhabdomyosarcoma, invasive orbital malignancies. So we're typically not doing exenterations for orbital fractures and orbital trauma. But to the question about what do we do if we don't have orbital implants, I guess your options would be to, one, do have a colleague or yourself harvest some type of autogenous tissue, whether auricular cartilage, try to improvise some type of thin plastic sheet, talk to Orbis about getting a donation, talk to Aesopers Foundation about getting donations, talk to the big companies like Stryker and KLS Martin about donating implants to you guys, or just doing a delayed fracture repair. Say, if the timing is not right, meaning that you don't have the right surgeon, you don't have the right equipment, and you're concerned that you're not going to have the best outcome, let them know, hey, we can have a great outcome for you. We just need to wait until we have the stars aligned, have the right implant, have the right surgeon, and then we'll fix your fracture. Why eyes remain white in orbital fracture in children? So why do the eyes remain white in orbital fractures in children? Is it because of the elasticity of the bones and green stick fractures? Yeah, so sometimes we have this term white-eyed blowout fracture or green stick fracture. And I think this is because this typically happens in young children, teenagers, even sometimes young adults in their 20s. The bones are very malleable and flexible. So instead of in an adult, the bone fractures and depresses, the children have very flexible bones. So it could fracture and then snap back up. And because of this, sometimes there's less orbital hematomas, there's less chemosis, there's less, maybe they're different types of fractures. They're not having these giant blunt force injuries. Hopefully, they're more likely to just be hit in the eye by a ball or something while playing. So the mechanisms of injury are different, and sometimes that's also why there's not a lot of retrobulbar hematomas, they're not on blood thinners, and a variety of reasons why kids are more likely to have a white eye blowout fracture. What do you expect from optometrists in facing an emergency ocular trauma situation? Well, optometrists are wonderful and are the primary eye care providers in many settings. In the US, there's many more optometrists and ophthalmologists, and patients might walk into the optometrist's office. And as we talked about, your goal as the primary eye care doctor or provider is to advise the patient appropriately. So you are responsible for helping triage the patient, figuring out who has muscle entrapment, who needs urgent surgery, who might need to be sent to the ER and call your oculoplastics colleagues for urgent management, or who can be triaged to say, hey, you don't have muscle entrapment, this can be delayed, we're going to wait for your double vision to resolve. We can always have the fracture repaired later, and counsel the patients about enothalmos, seeing that final result after 3 months, seeing the double vision results after 3 to 6 months and how most of it resolves, and then just talking briefly about how a fracture repair might work. So I see, in most cases, acute management is medical management, and I think and counseling the patient properly and triaging. And an optometrist can certainly do that very well if they're informed and educated. Do you recommend local anesthesia for ocular cardiac reflex control before surgery? So I always recommend injecting local anesthesia before any type of surgery because even though the patient is under general anesthesia, we know that intraoperative pain results in postoperative pain just through centralized pain mechanisms. And also, more importantly, for the epinephrine in the local anesthetic, we want there to be less bleeding when you go in, because if you have an ocular cardiac reflex, you still have to go in through transconjunctival incision, release the entrapped tissue, place an implant, close things up. And why would you want to have excess bleeding? So definitely use local anesthetic with epinephrine, even in cases that you're taking to the OR for an entrapped muscle. Next question, how we can see your educational operation videos? Ooh, this is challenging. I will say that filming orbital surgery is very difficult because you're in a dark hole. Oftentimes, you need to have a headlight, so it can be very difficult to watch this. I will make a plug for the Korn and Kikawa Atlas of Oculofacial Surgery, of which I have been an author of various chapters. There's beautiful videoing of various types of orbital surgery, as well as eyelid surgeries. So if you're hoping to augment your skills, that video atlas is a wonderful resource. It's called the Korn and Kikawa Video Atlas of Oculofacial Surgery. My colleague Richard Allen, who's our current ASOPR's president, also has a treasure trove of videos that he's recorded online, both for eyelid and orbital surgeries. And so I would point that out as a resource as well. You're also welcome to talk to Orbis and talk to the ASOPR's Foundation about arranging some type of preceptorship, whether you come to work with an oculoplastic surgeon in the US, or we arrange for oculoplastic surgeons to come and visit you and help you with your surgery. So that's really invaluable to have a preceptor and a mentor teaching you live and coaching you live. Yes, CAM is computer-assisted manufacture. Oh, okay. This was a question. This was a comment that computer-assisted manufacturing can be very helpful for DICOM data with CT studies. So that's great. Yeah, I mean, 3D printed implants, if you have the resources and it's not cost prohibitive, that can be a great outcome. But I will say that the pre-contoured ones to the average human orbit, there's not a lot of variation between the average human orbit. So that can sometimes be a much more cost-effective option. How to manage ocular cardiac reflex in orbital fractures. Well, you take them for urgent repair. So you have to pull the tissue out of the fracture site, place an implant to prevent re-entrapment, and then close up. So you take them to the OR and you free up the tissues that are entrapped between that minimally displaced fracture. Injection of atropine. No, I don't think I do atropine. I just take them back. Tell them to close their eyes. Don't move their eyes because that will prevent movement and traction on the muscles until they can go to the OR. How would you go about managing a patient with intravitreal hemorrhage alongside the blowout fracture with enothalmos and lid lacerations? So with the intravitreal hemorrhage, we typically want to minimize manipulation. Sometimes it's difficult to get a good exam with the intravitreal hemorrhage, and you might have a retinal detachment as well, which is even more reason why we don't want the vitreous to being moved around and the globe being manipulated. So again, if there's no entrapment of the muscle, you can have a very good outcome with a delayed fracture repair. So again, the answer is just do a delayed fracture repair and you can fix the enophthalmos later. If you can fix the eyelid lacerations in a minimally traumatic fashion that's not gonna put pressure on the globe, you can fix the eyelid lacerations, so that they don't have secondary intention and bad scarring. Thank you all so much for spending time over here today. Feel free to review the lecture, which will be posted on the CyberSite library. Please feel free to contact me again if I can help with anything. And please, if you have an interest in raising your level of orbital surgery and orbital trauma and fracture repair, please let Orbis know because there's a lot of us here in the US and all over the world who would be more than happy to make a trip out and help you guys. Thank you so much. Have a good rest of your day and evening.